Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. Let's begin our session with Kitab Al-Fatiha. So today is our first session on procedure presentation. This is your first kan? Tak pernah dengar online kan? So I must say this is not something usual. This is not something that we used to do. It is not even ideal. So when you talk about procedures and things, it should be hands-on. And I think as one of the IIUM graduate, I'm the 5th batch of IIUM medicine, graduated in 2006. One thing that separates us IIUM graduates from other graduates is our skills in hands-on. So usually when we start housemanship, usually IIUM graduates are more adept at doing procedures, because we encourage, we actually force many of you to do many procedures, deliveries. When I was student, I did even some surgeries with the surgeon, stitch something. So I think we actually allow and we encourage you to do so many things. But the problem, well, this is not something that is, well, COVID-19 is not something, it's global, and it's something that affects so many people around the world. So, but at least things must go on. Things must go on. We still need to proceed with whatever education that that we'll do, inshallah. Even when we won against COVID-19, we have some more session, and we'll brush up a bit more. Okay, all right. I've asked some of you to discuss about few procedures, isn't it? Who's presenting? Anyone presenting or macam mana? Tak dengar lah siapa ni. Jazli. Jazli cakap apa Jazli? I can't hear you.
Ada 3 orang Dr. present.
3 orang present.
3 orang.
So who's presenting?
Hazirah, Solhi dengan Jazz.
Can you hear me now, Doctor?
Okay. We can hear you now. Yeah.
There are 3 presenters, Doctor.
Okay, all right.
Hazirah, Sohi, and I.
Okay, all right. So who's going to start?
I'm going to start, and then will be followed by Hazirah and end with Sohi. So I'll be presenting about lumbar puncture. I'll proceed with sharing my slides. Okay. Assalamualaikum warahmatullahi wabarakatuh. Can everyone see my slides? Okay. Bismillah. Right. All right. Nice. Okay. All right. Video. Okay. Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Jazli bin Masabri, and I'll be presenting about the procedure of lumbar puncture. Okay, so here's the outline of my presentation. I'll be presenting about the start with the anatomy, the clinical anatomy, and then we followed by the clinical anatomy, and then we proceed to the procedure itself, whereby I will explain the steps needed to perform the procedure, and I will show you the video so that it will be easier to illustrate what's the procedure is all about. And I'm going to mention to you the indications for lumbar puncture, especially in pediatric cases, the contraindication and the complication of lumbar puncture procedure. So let's start with the anatomy. So when we perform the lumbar puncture, it's all about getting the cerebrospinal fluid from the spine. So we need to know roughly, we need to know exactly like what is spine and what is made of. So you can see here that we have vertebral bodies. We have 7 cervical vertebral bodies, 12 thoracic, 5 lumbar, 5 fused sacral, and 4 coccygeal. And you can see that the spine is not rigidly straight in line. You can see there is a form of kyphosis and lordosis at the lower end, and kyphosis at the upper end, superior end. So this is the general structure of the spine. What is more important regarding the anatomy is that the ligaments that's involved in stabilizing the vertebral bodies. Why? Because these are the ligaments that we're going to penetrate in order that we can extract the cerebrospinal fluid from the site. So you can see here that we have 5 in total ligaments that stabilizes the vertebral bodies. We have the interspinous ligament, we have the ligamentum flavum, we have the posterior longitudinal ligament and anterior longitudinal ligament. Okay, so when we perform the lumbar puncture, what happens is that we penetrate the interspinous ligament and we penetrate the ligamentum flavum in order to reach the potential space where we can extract the cerebrospinal fluid. Of these 2 ligaments, the ligamentum flavum is more thicker than the interspinous ligament, which gives that characteristic pop sound when you perform the lumbar puncture, and it also gives the characteristic feel of you manage to pass through strong resistance. So this at times when you perform the procedure, you can feel the difference in the resistance when you perform the lumbar puncture. So as mentioned previously, you have the supraspinous ligament, joint adjacent spinous process dorsally, interspinous ligament, joint adjacent spinous process and on horizontal surface. But the most important point for lumbar puncture is the ligamentum flavum, which is the thickest ligament and joins the adjacent laminae. And it is the immediate covering of the dura mater. Okay, so proceeding. So as you can see here, this is the posterior aspect of the patient, and as you penetrate through the ligamentum flavum, only then you can reach the cerebrospinal fluid, which is deep to the ligamentum flavum. But in this case, we cannot perform in any of this site because this is the cervical site. So it's not the lumbar region. Okay, so regarding the spinal cord, so when we perform the lumbar puncture procedure, we need to identify where is the end of the spinal cord, which is the conus medullaris. So based from the essential anesthesiology of our healthcare, second edition, they mentioned that the spinal cord in adults, they end at which is the conus medullaris, they end at the lower border of L1 and L2. Okay, it ends at the lower border of L1 and L2 in 94% of the population, whereby in 3% of the population, it is lower than L3, while another 3% of the population, it is above L1. So there is a small variance between the different between the people lah. So lumbar puncture between L1 and S2, so anything that's below the conus medullaris, are relatively safe. Why is that so? Because the conus medullaris are suspended, okay, suspended in subarachnoid space. When that happens, when you have the advancing needle, it will move with the resistance. It will not. It is not fixated. So when there is advancing needle, it will move freely in a suspended manner. So it is relatively safe. So I've attempted to identify whether there is any difference between adults and pediatric level for conus medullaris. From my readings, there is a difference in dural site, whereby in adults the dural site ends at S2, but in newborn it tends to be lower, which is at S3. However, for the conus medullaris, they mentioned that in the study they mentioned that in newborn the variance tends to be a bit higher. It could go between T12 up to L3, but on average still, the site is between L1 to L2, similar to adults. Okay, so we finished with the anatomy. Let's move on to the clinical anatomy. So this one is for the different sites of the spine, whereby for C7, how do we identify the clinical landmarks? The first prominent spinous process at the back of the neck. T1 is most prominent spinal process immediately follows T7, and T12 is we palpate the 12th rib and trace back to the attachment of T12. But what we want to focus down is for the lumbar puncture. So we attempt to locate the spinous process of L5. How? By make an imaginary line drawn between the iliac crest that cross between the body of L5 and L4. So when we position the patient in a sitting position, and then we try to identify the iliac crest, and then we try to make an imaginary line and demarcate which is the L4 and L5. Okay, so we finish with the anatomy, we'll finish with the clinical anatomy, then moving on to the procedure equipments. I'll go through briefly what are the steps needed, but it will be clearer when I will show you the videos of the procedure. So basically what we need a sterile dressing, sterile glove, sterile drape, antiseptic solutions with skin swab, lidocaine 1% without epinephrine, syringe 3 ml, needle 20 and 25 gauge, spinal needle 20 and 22 gauge. This one is important. It's a bit different from other form of needles. 3-way stopcock and manometer. But in our setting, I think they don't use this regularly. Instead, they used because they use the 3-way stopcock and manometer to assess the opening pressure. However, in our setting, we just put the line in a perpendicular manner, and we use a ruler to measure the height instead. Apart from that, we prepare plastic tubes number 1 to 4 with caps and syringe 10 ml which is optional. So how do we position the patient? So we put position in a lateral recumbent position with the hip, knees, and chin flexed. Why we do so? So that we want to open the interlaminar spaces. So in a study they have performed, they see that those who are in this position, they tend to have a better yield they have a significant decrease in cerebrospinal fluid opening pressure, but it is not really significant. Positioning, so other than the lateral recumbent position, patient can also stay in a sitting position. However, when we want to assess the opening pressure, we still need to position the patient in the left lateral position. And we have to be careful not to change the position of the spinal needle when we change the position of the patient from sitting to left lateral position. Okay, so as you can see here, the site of insertion. So basically, we insert in between L3 to L4, and we extract the cerebrospinal fluid here. Okay, procedure, what's the technique? I'll go through briefly. So L3 and L4, you first relocate, where is it? So L3 and L4 interspace by palpating the right and the left posterior superior iliac crest and moving the fingers medially towards the spine. So when we find that demarcation, we mark the site with a thumbnail or a marker. So we can put a marker so that we can easily identify the site. And then we can assemble the stopcock and the manometer, and we prepare for the local anesthesia. So as mentioned previously, in our setting, we tend to use a ruler instead to measure the opening pressure. So, and then afterwards, we proceed with the aseptic technique. We use the skin swab and antiseptic solution to clean the skin in a circular fashion, starting at the L3 interspace and moving to to include at least one interspace above and one below. So we do it in a circular manner so that we can remove all so that we perform the septic technique correctly. Place a sterile drape below the patient and a fenestrated drape is put on the patient. So patient is we have already prepared the site for extraction and it's already sterile. Then we can proceed with insert the needle all the way to the hub and aspirate to confirm the needle. It is not in blood vessel. So as we enter through the to the site, we want to ensure that we try to also aspirate along the way, minimally, just to see to what extent. Because by right, it should not enter the blood vessel because we only stop until the cerebrospinal fluid. And then we stabilize the 20.
Jazli, what do you mean by insert the needle all the way to the hub?
Yes, doctor.
What do you mean by insert the needle all the way to the hub?
Insert meaning I think it means like we insert until we feel the strong resistance, which is the ligamentum flavum.
Okay, proceed.
Okay. So we stabilize the 20 to 22 gauge needle with the index finger and advance it through the skin wheel, which happen when we perform the local anesthesia. But in pediatric protocol, they mention the spinal needle 20 to 22 gauge length of 1.5 inch with stylet. But for cases of children that's more than 12 years of age, we use a length of 3.5 inches instead. So this is based from PITS protocol. So as we enter through, we have to make sure it is parallel to the longitudinal dural fibers because we want to decrease the injury to the site. And as we advance through, we can occasionally hear a characteristic pop sound as it penetrates the dura. But occasionally we can hear, but we don't hear it all the time. Afterwards, otherwise the stylet should be withdrawn after approximately 4 to 5 centimeter and observe for fluid return. So I say usually it's common to see when you do lumbar puncture, after they reach certain site, they withdrawn and they see whether there is a flow of clear fluid. So this kalau yang macam those who usually observe people who do doctors who do the lumbar puncture, they usually, at one point they would withdraw the needle and they just wait and see whether there is a clear fluid that flow, and that should indicate the cerebrospinal fluid if it's sterile. But in cases whereby it could be bacterial meningitis, you can see some sort of stability in appearance. So for measurement of the opening pressure, the patient must be in a lateral recumbent position. After fluid is returned from the needle, attach the manometer through the stopcock and note the height of the fluid column. So you assess the height of the fluid column. The patient's leg should be straightened during the measurement of the open pressure, or a falsely elevated pressure will be obtained. So this is the procedure. After that is done, we collect at least 10 drops of cerebrospinal fluid in each of the 4 plastic tubes. If the extraction is low, you can ask the patient to cough or bear down or perform the Valsalva maneuver to hasten the procedure. So the sample we take, usually we take 4 tubes based on escape. We take 1 for cell count and differential. We take for glucose and protein levels. Green stain, culture and sensitivity. This one is important, whether a patient could have acute bacterial meningitis. Gram stain is one of the way to identify the organism, and we also do for cell count and differential. So I will show you the video for this procedure.
Mana video ni tak keluar.
Wah. Tak keluar. Apa? Share kat browser eh? Tak nampak eh? Oh, tak nampak. Okay, kejap. Aku adjust ni. Screen browser. Kejap. Screen browser. New share. Nampak ke? Saya just go. Okay. I'll just go skim through the important bits. So as you can see, first you position the patient. You put him in this position. And then you can see here he do the septic technique, and where he perform he put the antiseptic in a circular manner. And then you can see that the doctor put on a fenestrated drape. So for to the area side, and he attempts to locate the L4, L5 position based from the posterior superior iliac spine. And then the doctor inject the local anesthesia. As mentioned, as the doctor inject, he slowly try to extract intermittently to ensure that it does not enter the vascular area. Okay, and then you use the spinal needle to enter the site. You should be in perpendicular manner, and then you can see the doctor withdraw the needle to see whether there is a flow of cerebrospinal fluid. Okay, there it is. Cerebrospinal fluid. I think that's it for the video. Okay. So continuing. So how do we analyze the cerebrospinal fluid? We, based on PIS protocol, we can see for acute bacterial meningitis, we should expect the leukocyte should be high. You can get from 100 up to 50,000, and the protein usually it could be slightly higher because you can reach from 1 to 5. And the glucose is reduced because you use the bacteria consume this glucose. So you can get lesser than 0.5 or you can get 1.5. And you could do an extra gram-stain positive investigation, as mentioned previously. You assess whether the patient could have acute bacterial meningitis. In partially treated bacterial meningitis, the leukocyte could be slightly lower, and the protein could be elevated. but the glucose would be low. But so the difference between acute bacterial meningitis and partially treated mainly is the extent of the leukocytosis. It could be slightly lower compared to the acute bacterial meningitis. Cerebrospinal fluid can be sterile in pneumococcal and meningococcal meningitis. So for tuberculous meningitis, the leukocyte quite not as high as the acute bacterial meningitis, but the protein is high with low glucose. But we have to perform the investigation to assess for tuberculous meningitis, where you do smear AFB or gene expert for MTB test. This one is more routinely done compared to the gene expert MTB. Fungal meningitis.
Just to remind, this glucose, it is in relation to serum glucose. It's not the absolute value 0.5 gram per deciliter. That is in relation to the serum glucose.
Oh, I see. Oh, I see, doctor. Thank you, doctor. In relation to serum glucose. So for fungal meningitis, 50 to 500 lymphocytes, protein could be a bit low, the glucose could be normal or low, but you can do cerebrospinal fluid for cryptococcal antigen, and I believe we can do also Indian ink to assess for cryptococcal presence of cryptococcus. In encephalitis, leukocyte is not as high, and the protein and glucose tend to be normal. So we can perform the cerebrospinal fluid for virology. Okay. Okay, so what's the indication for lumbar puncture? We do it if it's suspicious of meningitis or encephalitis. We can also perform in intrathecal chemotherapy for oncology patients. In extension of this, outside of like PITS cases, you can have do can do if you suspect patient of having GBS, or it could be a form of therapeutic also in pseudotumor cerebri. But this is not a PITS case lah, because this one is usually associated with obese women of childbearing age. So it means that lumbar puncture can also be performed as a therapeutic reasons. So what's the contraindication for?
Why not in pediatrics?
I think because in this case, based from the indication here from Medscape, they mentioned that it is performed in idiopathic intracranial hypertension, and this case usually is in common for women of childbearing age. Sorry, doctor. Doctor is on mute.
No, what I'm trying to say is, we can tap the CSF for intracranial hypertension. We can tap the CSF for intracranial hypertension. For example, in patients with hydrocephalus, we can tap, but we don't usually do lumbar puncture lah. So we can tap, but we do basically direct from the CSF tapping from the anterior fontanelle. So we can do that. There are reported cases where they even do to reduce the intracranial hypertension. They do from lumbar puncture. Is also reported as well. So you can do, but we need to be cautious. Okay, sorry, proceed.
Okay, thank you, doctor. So what's the contraindication? The contraindication is for hemodynamically unstable patient with a Glasgow Coma scale of 8 or lesser. Any abnormal dorsal eye reflex or unequal pupil. I will explain more about the abnormal dorsal eye. Any lateralized sign or abdominal posturing, I will explain further later on the lateralization. Immediately after recent seizure, any evidence of papilledema or bleeding tendencies, if the platelet count is 500,000 or lesser, and presence of skin infection.
50,000, not 500,000.
Oh, sorry, 50,000. 50,000 per millimeter cube, and presence of skin infection. So in regards to the doll's eye or abnormality, what happened is that basically an assessment of the vestibular ocular reflex. So vestibular ocular reflex is used for neurological examination, of cranial 368. The reflex arc include the brainstem nuclei, overall gross brainstem function. So what happened in a normal case, there is basically we should have like a fixated gaze. So in a normal case, you can see this person. If they look, how we perform the procedure, we hold the patient's head and open the eyelid, and then we try to rotate the head. The eye should be fixated to a place. So if we move the head away from the from our direction, the eye should fixate to us. However, in a case whereby they have an absent or abnormality of this those eye, as you rotate the head, the eye is only does not fixate at one point. It just follow with the rotational movement. So that's why this is called a doll's eye, because it does not like fixate. So this is in abnormal cases, there is absence of this reflex. And this reflex should be present by the age of first week of life already. So lateralization, I'm not quite sure. I don't really understand what it is, but I believe it's something about having a more dominant traits of one side of the cerebral hemisphere, meaning like it's like when you do post-ictal nose wiping lateralizes to the hemisphere, ipsilateral to the hand using for nose wiping. Macam the brain macam dominated at one side of the brain hemisphere. Otherwise, I'm not really sure what it is.
Lateralizing means just some symptoms and signs that is associated with basically unilateral lesion. So it just suggests that if there is this sign, it says that there is lateralization, meaning the problem is on one side of the brain. It is not something global. It's not something like meningitis where you have it's a generalized problem. This is it's a focus. There's a focus of lesion that's causing all these things.
I see, doctor. Okay, thank you, doctor. So we're approaching the end of our presentation. So the last bit will be the complication. The main will be post lumbar puncture headache. You can have also infection, bleeding, cerebral herniation, minor neurological symptoms such as radicular pain or numbness, late onset of epidermoid tumor of the thecal sac, and back pain. But among all the complications, the backache is the most common, which accounts 25%, headache accounts 22%, headache and backache 12%, and severe radicular pain in 15%, and paraparesis in 1.5%. In one of the common complication is post lumbar puncture headache. The headache occurs 10 to 30% of patient, and it is one of the most common complication. It happens when you extract too much fluid. So how does that happen? Because the post lumbar puncture headache is caused by leakage of cerebrospinal fluid from the dura and traction on pain sensitive structure. And it is only diagnosed for cases within 24 to 48 hours after the procedure, whereby patient usually presented with frontal or occipital headache and exacerbated in upright position and improved in supine position. For that reason, usually after we do lumbar puncture, we ask the patient to lie down and rest in supine position, and we do continuous monitoring for the patient because patients tend to have this complication of post lumbar puncture headache. Though associated symptoms may include nausea, vomiting, dizziness, tinnitus, and visual changes. So these are my references. Medscape, up to date, article, and NS. I think that will be all.
Any questions to the presenter?
I have a question regarding the lateralization sign just now. Doctor, you mentioned that it indicates that it is a focal lesion of one hemisphere. May I ask why is it a contraindication? Is it because of possibility of abscess or tumor, doctor?
Let's allow the presenter to answer first.
Oh, okay, that's
Jazli,
Yes, Doctor.
what do you think is the answer?
Mm, I'm not really sure, but I think it's because the in the contraindication, usually the issue is with neurological symptoms. You can see by patient presented with the abnormality of the doll's eye, presence of Glasgow coma scale of 8 or lower. So in that cases, we want to avoid performing lumbar puncture. So I think this is part of that concern.
Okay, Jazli, look at your contraindications.
Yes, Doctor.
Okay, so these are the contraindications. So among, let's see, so lateralized signs, abnormal posturing. If you see here, it's actually many of what are most of this. What are the commonest cause for most of this?
Tumor,
Increase intracranial pressure.
intravenous pressure.
So basically because of increased intracranial pressure. So if
Oh.
what's going to happen if there is increased intracranial pressure and then you open up, you tap below it, what's going to happen?
Can cause cerebral herniation.
It can cause cerebral herniation. Yes, it can cause cerebral
Um,
herniation. So this is among the risks that we need to watch out. So that is why ideally, if you want to do lumbar puncture, you need to make sure that there is no signs of increased ICP. So if there's increased ICP, then the problem is you can cause cerebral herniation. And you know, if there's herniation, then the prognosis will be very, very bad. Okay, clear. Okay, my question. So if no one wants, or anyone else want to ask any question before
Doctor, I
I.
would like to ask.
Okay.
One question. In peace protocol mentioned that we need to take the random blood sugar after the lumbar puncture.
Yep.
Why exactly? Why we take after?
Jazli,
Random
why?
blood glucose. I believe from what doctor have mentioned previously, the glucose that we take for assessment in cerebrospinal fluid is not the amount of glucose inside the cerebrospinal fluid itself, but it's in the relation of the serum glucose. So we take the random blood glucose to compare with the glucose content inside the cerebrospinal fluid.
Yes, because the value of glucose value in your brain, it will correlate with your serum blood glucose, isn't it? So if your blood glucose is high, if your serum blood glucose is high, so in the brain, in certain condition, it will be lower, in certain condition, it will be higher. So this is how we interpret. Okay, so when you interpret blood glucose level in CSF, it should correlate with serum blood glucose.
Yes, doctor. But my question is actually why we take the random blood glucose
Ah.
after we do the lumbar puncture. Why not before? Is it any difference?
Or during? What? Jazli?
I'm not sure about that. I'm sorry.
Okay. If you ask me, I don't like to do it after. You wanna know why? I prefer to do it before.
Oh,
You know why I prefer to do it before?
Because patient is agitated after lumbar
No,
puncture.
because doing lumbar puncture is a stressful procedure.
oh.
Isn't it stressful? You stress the patient. There's procedures. So what is produced when you are stressed?
Cortisol.
Cortisol. So you increase cortisol. So what happens when you increase cortisol?
Elevated.
So your blood sugar will be elevated, isn't it? So sometimes actually if you do after, your blood sugar tend to be a bit higher. That is why ideally it should be done before. I don't know why peace protocol says after. Again, peace protocol is not actually agreeable by all pediatricians. But okay, but one reason, if you ask me, one reason why we do after is usually because lumbar puncture, the failure rate for lumbar puncture can be as high as 50%. the failure rate, so meaning how good you are, sometimes if you do lumbar puncture, only 1 out of 2 is successful. The commonest complication of lumbar puncture is actually failure.
I see.
Especially in smaller children, isn't it? Why
Sorry,
small children is more difficult?
because difficult to for compliance for positioning.
Yes, that's one thing. The other thing is because usually in smaller children, it's difficult. You don't actually give sedation most of the time.
Mm.
You obviously even in adults you don't give sedation. We don't usually give sedation usually for lumbar puncture. But in adults you can ask them, keep quiet, don't move. In children, you cannot tell them. You can't tell premature babies to keep still and not move, isn't it? So they'll move about. That's one thing. The second thing is, can you imagine their vertebra is just this big. So if their vertebra is this big, what is the size of their cerebrospinal space? It's very small.
Yeah, small.
It's very small. So the area that you're gonna poke is very small as compared to in adults. So failure rate in
Mm.
children is a bit higher. No, it's not a bit. It's much higher than in adults. So sometimes if you take before and then you can't get it, then you need to repeat another time. So sometimes people just do after, so that when it is successful, then only you take blood. So probably that's the reason lah. But if you ask me, ideally it should be done before, so that we can get a more correct random blood sugar. Okay, any other question?
So doctor, I would like to ask, based on the contraindication, basically it says about signs of increased cranial pressure. So if patient have like vomiting, headache, presentation, but without presence of papilla edema, do they still proceed with lumbar puncture or depends on the situation?
Okay, the answer is anyone wants to try to give an answer first before I answer. Do we still have time? We still have time. Okay.
We can do imaging like CT brain first to see any evidence or any localizing.
Okay. All right. Okay, that's good. Okay, what else? Who else has any idea? Increase ICP. If the child has vomiting, nausea, can we proceed with lumbar puncture or not? Anyone else has any idea? Mana orang-orang lain ni? Syamimi macam ada idea bernas kat belakang tu.
I'm not sure, doctor.
Zafira. Selalu seorang senyum lebih dia ada nampak pandangan yang ni. Nur Zafira. Idea?
I'm not sure, but in adult, we can do like endoscopy to look for any edema to now increase the ICP. In children, I'm not sure.
Okay, so the answer is first, in a child that is nausea and vomiting, you don't. Okay, are you sure it is because of increased ICP? So first you need to use your brain lah, whether it is increased ICP or is it because of pharyngitis or is it because of meningitis. So irritation on the meninges also can cause nausea and vomiting, not because of increased intracranial pressure. So you need to use your brain and assess whether is this nausea and vomiting, is it because of meningeal irritation or is it because of pharyngeal irritation, or is it because of gastric irritation, or is it because of increased ICP? So there are signs of increased ICP, papilledema, sunset eyes. So there's so many other signs, proper projectile vomiting. So you need to look at all these things and then you decide. If there is symptoms and signs suggestive of increased ICP, probably lumbar puncture should be delayed. So probably you need to prioritize doing imaging, for example. isn't it? You can do CT scan or MRI earlier for you to look at the other things first, assess the intracranial pressure, then only you proceed with lumbar puncture. But okay, any other question before I ask question? I
have question, Doctor.
uh,
The level that we do lumbar puncture in adult is at between L4 and L5. In pediatrics between L3 and L4. But what is the cut-off age that we want to say that the patient need to do L4, L5? The cut-off age for pediatrics patient.
no, okay, Jazli, I need to ask the presenter lah, answer dulu kan.
So the question was, Mimi, what is the cut-off age to choose whether to do between L3, L4 or L4, L5? Is it?
Yes.
From my understanding, there's no sort of cut-off age because the main concept is that the conus medullaris ends at L1 or L2. Anything that's lower than that is supposed to be relatively safe because all the spinal cords are in suspension. So you don't get any trauma from any of the extraction. So it's by right you can it does not matter.
Okay, so my answer will be this. It doesn't really matter where you do it, as long as you don't do above L2. So because you know the end of the spine is at the L2 level, and even at L2 it is still quite safe, isn't it? So as long as where is L2? So you look at the spinous you look at the what is that, iliac crest, isn't it? Posterior superior iliac crest, that is L3, L4. The uppermost level of iliac crest is actually L2 level. So you don't do above that. So you make a line between the upper top border of your iliac crest, that is L2. So you should go below that. Anything below that is safe. So anything below that is safe.
Okay, thank you, Doctor.
Any other questions?
Doctor, for the amount in child, is it same with the adult? Because in adult we use 10 drops for each tube. For child, is it the same?
It depends. It depends on what test you want to do. It depends on what test you want to do. It depends on your lab. So if your lab can do the test with 5 drops, you can do with 5 drops. If your lab needs more, then you need more. If you want to send for viral studies like HSV and things, so viral studies are usually done centrally. So you don't do here, you do only in KL, and only several labs in whole Malaysia can do viral studies. So obviously you need more sample for that. If you want to test for neurotransmitters, for example, you want to test neurotransmitter, obviously you need to send more. So it depends on, my answer is it depends on the test you want to send, it depends on your lab you want to send. Because if your lab is very capable, they can do with just 5 or 4 drops. Yeah, but if your lab is not that good, very new lab and things, so sometimes you don't expect them to do it well, isn't it? So you need a bit more sample. Okay, let's go few things. What is the problem with lumbar puncture in Malaysia?
Parents refusal.
Consent. Why is consent a problem in Malaysia? In UK, it's just verbal consent. It's just like you put a line. You just say, parents, I want to do lumbar puncture. Then you do. In Europe, in many countries in Europe and in Canada, they just do lumbar puncture like you do line setting, like you do venipuncture. You don't even tell. So why in Malaysia you need the proper written consent?
Stigma, Doctor? Stigma with the procedure.
Okay. Aklan was saying to say something?
The stigma of the invasiveness of the procedure.
Okay. What is the stigma? What is the stigma in Malaysia?
And cause paralysis.
Huh?
And cause paralysis.
Paralysis.
Yes. There is a myth. There is a myth in Malaysia among Malays only. Not among orang asli, not among Chinese Malaysia, not among Indian Malaysian. Only among Malay Malaysians. Saying that if you do lumbar puncture, you'll be paralyzed. So what do you say to this? If you have a baby with meningitis, you want to do lumbar puncture, you counsel the parents. Parents say, doktor, ada ustaz saya cakap kalau buat lumbar puncture jadi paralyzed. So what are you going to say?
The danger of meningitis is way higher, and the fact that it is spinal cord actually can be, the spinal root can be evaded actually once we entered the needle.
Okay, so first thing is this is not true lah. There is no evidence at all saying that lumbar puncture can cause paralysis or anything. Lumbar puncture doesn't cause lumpuh. Lumbar puncture does not cause kelumpuhan. I've been working since 2006. I've never seen a case. I think there's no reported case of paralysis after lumbar puncture. There's no case. There's no case. The thing is, sometimes this is the problem with Malaysia. When you want to do lumbar puncture on children, there will be lots of problem. But if you want to do lumbar puncture and spinal in female for anesthesia, it's not a problem. Despite it being the same procedure, isn't it? You want to do spinal, and for spinal or epidural, it's the same thing. You puncture at the same site. Furthermore, if you do spinal or epidural, it is more higher risk because you are giving drugs through it. So lumbar puncture is much safer. And so when you do it in adults, they didn't say anything. But the moment you do in children, they say so many things. So these are just myths. There are no truth in it. There's not that we've never had problem among orang asli. We don't have problem among Chinese. We don't have problem among Indians. Only in Malays this problem persists. I don't know why. Who says this? These are all bomoh punya cerita lah. So that's one thing. So but we do need to know. So we can explain to them. So what I usually do is I usually draw the spine. I usually draw the vertebra. These are the spinous process. These are the CSF space that we want to go. This is the brain. And usually meningitis infection is in the brain. Why we do at the lumbar region? Why don't we poke the brain? Why we don't poke there? The infection is there, isn't it? Not at the back there. So why you do lower down? Meningitis infection is in the brain. Why? Yes, because CSF circulates everywhere. So it's a pool. It's a connecting fluid. So you obviously you don't want to poke the brain because there's brain there, isn't it? So there's brain there, there's risk of injury, even though it's very low, even though by itself that is not that high even. But to reduce the risk of nerve damage, so you do at the lumbar region where there is no nerve. There's no nerve roots there. It should be safe. It's just fluids. There's no spine there. There's no spinal cord there. So it should be very safe. Okay. So and then a few things you need to remind when you counsel. So first, lumbar puncture is best if it is done early. Why if it's best if it's done early? Can we do it after, like, you admit today and then it's night, so you say, okay, fine, I'm not going to do at night, you do tomorrow. Is it okay?
Partially treated can cause the values to be deranged, doctor.
Why it become deranged?
Because of the effect of the antibiotic, it can reduce the bacterial load actually in the CSF.
That's true, it reduces the bacterial load. So if you reduce the bacterial load, obviously you won't get good culture from it, isn't it? So you need to do it as early as possible. So ideally, it should be given even before antibiotic. But sometimes if you delay, it shouldn't cause you to delay antibiotic lah. You still need to give. So treatment you need to give, but ideally it should be done as early as possible. So lumbar puncture should be done as early as possible. Okay. Let's go to your earlier slide. Okay, few things I want to say. In children, we don't do many things similar as adults. Rarely we give analgesia for children. Rarely. Sometimes in certain patients we do give some sort of sedation. It depends on the patient lah. Sometimes we do give some sedation, but generally we don't even give sedation. It depends. For newborn babies, we don't usually give sedation. Usually we just give sugar. We just give some sugar, the baby sucks on sucrose or something. That should be adequate for newborn babies. So we don't usually give sedation. Sometimes we give, but usually we don't give. We don't usually give analgesia as well. Because you know, in children the space is very small. The space is very small. In newborn baby, some more dia punya muscle pack dekat belakang tu is thick. So if you give local anesthesia, you can't even feel the spinous process afterwards. So you don't usually give. So and then the space is very small. So the more you disrupt the space, the more problematic for you to actually reach the area. So you don't usually give. And then can you use the usual needle? The usual like blue needle or whatever color needle,
No,
not
it's
the proper
different.
spinal needle.
I believe cannot because it's not suited for the procedure.
So you can, but it is not safe. So ideally you need to use a proper spinal needle, because using proper spinal needle, it reduces the risk of injury, it reduces the risk of bleeding and things. You need to remember, below your vertebral bodies there are blood vessels there. So sometimes if you poke through the blood vessel, you may rupture and you can see some bleeding. So you can get traumatic CSF. So it's because when you puncture the vessel just below the vertebral bodies. Okay, and then can you do sitting position in children?
Yes, if you're not planning to assess for opening pressure.
So in
But
children, in children we don't usually do opening pressure, because why? Because you don't sedate them, they don't sit quiet, so it's very difficult for you to actually do proper manometry lah. It's very difficult in children, so we don't usually do in children to assess the pressure. We don't usually do. We can do, but we don't usually do. Okay. Can you do sitting? The answer is can, but usually you only do in bigger children that are cooperative. Budak umur 11, 12, 13, they can cooperate, we can do sitting. Or newborns, can you do LP sitting in newborn? The answer is can lah. Can is not the good question kan. If you ask can, the answer is usually can. So obviously can. So in newborn babies, you can do lumbar puncture sitting, but sitting lumbar puncture, we don't usually do it. So many of us, many pediatricians are not that confident in doing sitting lumbar puncture in newborn babies. But I was told it's much easier. I've tried several times and I don't particularly like it. I prefer in a usual position, which is lateral position. Okay. Next thing is, you don't usually hear the pop sound, but you can feel the pop. You can feel the pop. So because obviously in newborns, especially in children, the dural space and everything, it's not as firm as in adults. So you don't usually even in adults you don't actually hear the pop, but you feel the pop. You feel when it changes the resistance. Okay. What else I want to say? Okay, the most important is basically contraindication and how to explain to the parents. The site I've mentioned. Okay lah, I think that's it. I think that's it for lumbar puncture. So lumbar puncture is among important procedure for you to have an idea and ideally could see lah. Oh, one more thing. When you interpret CSF results, you need to interpret with caution and with think. You cannot just say when you see WBC, you just say, so this is meningitis. You need to use your brain basically. As clinician, you need to always put on your thinking hat. You need to always put on your thinking hat. For example, okay, I give you one problem. When you'll know I just reported back for duty in January. So I went for my subspecialty for 3 years. I just came back in January. So in January and February, what we noticed that we have so many patients with positive CSF. Meaning when we do lumbar puncture, almost everyone has positive leukocytosis in the CSF. What do you think you should do? What do you think may be a problem?
Sorry, Doctor, I'm not sure.
Okay, so what happened was, so usually getting a positive CSF is not that common, because sometimes we do CSF in certain patients that we think it looks like meningitis, so we do lumbar puncture to actually rule out meningitis, or in newborn babies with GBS or with sepsis that we think we need to do lumbar puncture. The problem with us initially was all lumbar puncture came back as positive with high leukocytes. So we did, I think after a few weeks, then we did report with, we did several times. We reported to our lab technician. We reported to our lab microbiologist as well, clinical microbiologist. We said, this is very unusual to have almost 100% of our lumbar puncture to be positive with high WBC count. This is abnormal. This is not common anywhere in the world, where almost 100% of your lumbar puncture comes back as positive. So I think after third event, then only after third time we complain. So when we complain, meaning every time we get positive for so many times. So after third complaint, then only they managed to go back to their procedure. And you know what they found is there is contamination in the reagent. So how they process the CSF, how they interpret, they look at the slides, the way they process, there's a reagent that they use. Apparently that reagent is contaminated. That reagent is contaminated. So what I'm trying to say is, when you see results, you need to interpret it with caution, and you need to use your clinical judgment and clinical acumen, because sometimes there may be error. There may be error at processing. There may be error at like this. It's a reagent punya problem. So, and if you see something that is not right, you should always try and clarify, try and rectify. Do not accept things as it is. If you think something is abnormal, something doesn't look right, you should always say, this is not right. Kan? Islam taught us, when we see something wrong, we should correct with our hand. If we can't with our hand, correct with our mouth. If we can't correct with our mouth, at least we must feel this is not right. Okay, all right. Let's go to the next. It's already 3:15. Okay.
Okay, next presenter would be Hazirah Suri on chest tube.
sorry.
Yep, proceed.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you see my slide? Hello? Can you see my slide?
Yes.
Okay. Okay, today I'll be sharing about chest drainage. So my references are from PITS protocol and also up to date. So first of all, we need to know what is the definition of chest drainage, or in other words, tube thoracostomy. It can be either standard tube or pit tail. It is a very common procedure done in the ward in which any tube or small catheter is placed through the chest wall and we insert it into the pleural cavity. It is used primarily to drain the air and also fluid. And also it can be used to instill agents to induce pleurodesis. Pleurodesis is we instill agents to make the lung adhere to the pleura, to the chest wall. We did it in case of refractory effusion or also to treat lymphedema. Okay, these are the indications from up to date. But in PITS protocol, just mentioned that the indications are pneumothorax, pleural effusion, and also lymphedema. So indications in the up to date divided into pneumothorax, hemothorax, pleural effusion, and pleurodesis. So for pneumothorax can be either spontaneous, traumatic, iatrogenic tension, or extension of mediastinal air, or air leak following pulmonary resection, and also bronchopleural fistula. And usually in bench pneumothorax, we usually do needle thoracostomy first before proceed to the chest tube. And then pneumothorax can be due to chest trauma, post-operative, and also other cardiac or aortic conditions. And pleural effusion can be caused by sterile effusion, infected or inflammatory effusion, malignant effusion, and also cyclothorax. Cyclothorax is accumulation of the lymphatic fluids in the pleural cavity. And also
Hazirah,
yes?
It's not cyclothorax, it's chylothorax.
Chylo. CHY, right? No.
Yes, CHY. Chylo. It's chyle.
Chylo. Okay. And then pleurodesis. As I have mentioned just now, pleurodesis is installation of the sclerosing agents into the pleural space for the treatment of refractory effusion. Okay, next we move on to the contraindications in up to date. Just mentioned about the relative contraindications, in which among the relative contraindications are if the patient is on anticoagulation, if the patient has coagulopathy, overlying infection over the skin, and also a bleeding diastasis. But it is mentioned that if the patient is acutely injured with concern for massive hemothorax or tension pneumothorax, then we can still proceed. For example, you can use needle thoracostomy, maybe preferred as the initial option in the patient with coagulopathy. And then it is said also that the transudative pleural effusion due to liver failure are not generally managed with thoracostomy drainage.
Hazirah, why is it just relative contraindication? Why is it not a contraindication?
Because in some patients you can still proceed with the chest tube insertion if the condition the condition is severe.
No, the answer should be if a patient has pneumothorax, even though there is coagulopathy, the patient will die if you don't do chest drain. Because having a lung to breathe is more important than bleeding. Because if you bleed because of coagulopathy, you can give FFP, you can give cryo, you can give whatever factor you want to give. But if you don't have lung to breathe, then you will die. Lah. So that is why it is a relative contraindication. So meaning that if you have a patient with coagulopathy, so if you want to do chest drain, you need to think whether you need to do or not. Is the pneumothorax worsening or not? Is it indicated or not? Can you wait or not? Do you need to do it now and now, or can you wait for transfusion and normalizing the coagulation profile before you do? So this is why it's a relative contraindication. If there is an overlying infection, if there's empyema, and sometimes if you poke on it, if you have tuberculosis, for example, tuberculosis is a problem where if you do chest drain, you will create a false tract on it. Faham? Dekat tempat yang you puncture tu, you will create a false tract with the tuberculosis. So if there is infection, you need to think whether do you actually need to do the chest drain, or can you actually wait, or can you, if the pneumothorax is not that severe, so probably you can wait and see whether it improves or not. So that's the reason why it is a relative contraindication. Okay, all right.
Thank you, Doctor. And it is said also that the patient with pleural adhesions, previous pleurodesis, or patient has prior pulmonary surgery, blind implantation of the chest tube is dangerous. So we need guidance by ultrasound or computed tomography scan. Okay. Next, we move on to the issues in pediatric populations. Okay, there are two issues, which is the first one, chest tube sizing and placement, and also management and complications. For the chest tube sizing and placement, usually the tubes are smaller caliber for children, and also it is said that more often using Seldinger technique. Okay, I will explain more about the Seldinger technique later, and also about the size of the tube. Okay, for the management and complications, it said that the complications are considered the same as in adults, and among the potential complications are nerve or artery damage, inadvertent damage to surrounding structures, such as damage to chest, mediastinum, diaphragm, or abdomen, and then infection, hemodynamic issues with rapid fluid evacuation, and also re-expansion injury. Re-expansion injury or re-expansion pulmonary edema is caused by the rapid emptying of the pleural cavity due to the chest drainage, and then inadvertent tube displacement, and also pulmonary or inpatient site infection. Okay, these are all the complications, and this is another list for complication of thoracostomy, in which it divides into during the procedure and also post-procedure. Okay. Then for the preparations, okay, first mention about the antibiotic prophylaxis. For antibiotic prophylaxis, in spontaneous pneumothorax, it is said that it is not warranted, and in penetrating trauma, it is warranted, particularly if the patient has penetrating injury. And also for elective thoracic operations, it is only administered as a preoperative dose, not continued until the surgery. And then we have to take proper history and also do proper physical examination on the patient. Okay, we have to look at the clinical features pertinent to the current indication. For example, in thorax, chest pain, shortness of breath, and then elements that might impact the tube placement. What can alter the way we put the tube into the chest? Okay, for example, if the patient has cardiomegaly, situs inversus. Situs inversus is congenital condition.
Why cardiomegaly is a problem?
Because when there is cardiomegaly, then the heart will expand until the move to the lateral part of the chest, in which we can poke in the chest tube at the axillary line, right? So if the heart dilate, then it can cause we poke into the heart.
So basically, you need to be more careful lah, because the heart is very near to your pleura. If you puncture it a bit more, if you give a bit more pressure, then you will accidentally poke the heart, which you don't want to use. If you poke the heart, then you need to call vascular surgeon, you need to send the patient to IJN. So this is all massive problem.
Yes. And then in situs inversus, or another name is situs transversus or situs oppositus. It is a congenital condition in which the major visceral organs are reversed or mirrored in the opposite direction from their normal position. Okay, and then mediastinal tumor, prior thoracic surgery, prior chest tube placement of fluorosis can get the scar, and then the presence of medical devices such as central venous access, port, pacemaker, defib, shunt tubing, and also nerve stimulator. We have to avoid from poking at this site, and then the bleeding diastasis, in which the patient has bleeding tendency, or the patient has antithrombotic therapy, or the patient is obese, has scoliosis or chest wall deformity, in which can alter the position of the chest. Okay, and then we have to look at the factors that elevate the diaphragm, because we don't want to poke at the diaphragm, so we have to be careful about the factors that elevate the diaphragm. And also other factors that we have to consider in pediatric population include diaphragm integrity, functionality, and height. Okay, because we don't want to cause injury to the diaphragm. And then we have to also exclude other conditions that may mimic pneumothorax on radiograph, such as cysts or pulmonary abnormalities or congenital malformations. And then developing breast tissue in prepubescent females. Okay. Okay, this is for the antibiotic prophylaxis. Usually we give cefazolin or ampicillin sulbactam or vancomycin or clindamycin. Okay, and then after that, about the tube selection, usually we use silicone or polyvinyl chloride PVC tubes that have a radio-opaque strip. So it has the drainage hole along the tube. And also in chest tube, the sizing of the chest tube using the French sizes. So what is French sizes? The diameter in French divide by 3 equal to diameter in millimeters. For example, the diameter in French is 18. So 18 divided by 3, diameter in millimeters is 6. And R size based upon the weight of the patient and indication for placement. Okay, I'll show you later the table of the size. And then, okay, we'll explain later about this. And then for pediatric chest tube size, okay, there's also we call it as general rule of thumb, in which the estimated uncuffed endotracheal tube size times 3 is the size of the chest tube. Meaning that if you want to know the chest tube size, we have to time the endotracheal tube size by 3. So how we want to know the endotracheal tube size is by 4 less h minus by 4. However, I'm not sure whether it is used or not in the clinical practice. Okay. And then it's said also in the large case series, pigtail catheters were highly effective for pleural, serous, and also chylous effusion. But it is less effective for blood and air, and least effective for empyema. And it is said also pigtail catheters also appear to be more effective in infants and younger children compared to adults.
Why do you think pigtail is less effective for blood?
Because it is smaller in diameter, so it can cause clot and blockage.
Yes, so yes, clot blockage. Yes, sebab dia ada banyak, dia fenestrated kan, dia one hole, dia smaller, and then dia multiple ni, so more areas where it can cause clots. Okay, alright.
Okay, this is a picture of the standard chest tube, in which there is a drainage hole. You can see here, drainage hole, and also the radio opaque marker, the blue radio opaque marker. Okay. And there are two types, which is straight and angle thoracostomy tube. It is said that the angle thoracostomy tube is used in the surgical setting to assure placement in the posterior costophrenic sulcus. We don't want it to move around, so we put at the costophrenic angle. Now, this is about the sizing of the chest tube. Okay, the above table is from up to date, and the statement below is from PITS protocol. So in up to date, it divides into neonate, infant, and also preteen. So for neonate, usually less than 5 kilogram. The size is different from air, serious fluid, pus, and blood because air and serious fluid will use smaller caliber compared to pus and also blood usually. Okay, and then this is from PITS protocol. It said that usually if the child is less than 2 kilogram, we use 8 French size, and then for more than 2 kilogram, we use 10 French size. Older children can use 12 to 18 French size, depending on the size of the child. Okay. Okay, for preparation, first for the patient positioning. Okay, so in adult, we put the patient in supine position with its lateral arm abducted and elbow flexed to position the hand comfortably over the patient's head. But for pediatric population, I said that consider the supine position for children with 30-degree head of bed elevation, meaning that we elevate the head a bit for about 30 degrees to allow for decreased height of the diaphragm in children. Can also be done in sitting position for those suspected of having high diaphragm. And also we can consider nasogastric tube for air aspiration from the stomach in a child to lower the height of the diaphragm. So the main consideration in child is about the diaphragm. Okay. And then about the analgesia and also sedation. In emergency clinical setting, the chest tube can readily be inserted under local anesthesia. Usually we use lidocaine with or without intercostal nerve block. In the elective setting, we can give oral, intranasal, or intravenous sedation prior to tube insertion, in addition to the local anesthesia use. Okay. This is about the local anesthesia. Usually we give lidocaine. Okay, the maximum allowable dose is 4 to 5 milligrams per kilo. And then this is I got from Hospital Ampang, which during the time I did my elective posting. It is about the commonly used drug for sedation in pediatric patients. However, I'm not sure whether it is used the same across Malaysia or not. So these are the pediatric dose for each of the drugs. For example, midazolam IV we give 0.05 to 0.1 milligram per kg, IV 3 minutes before procedure, and not to exceed cumulative dose of 0.5 milligram per kilogram or 6 milligram. Okay, can read about the others. Okay, for the insertion site, most clinicians insert the chest tube via incision at the fourth or fifth intercostal space in the anterior axillary or in the mid axillary line. But in the emergency situation, we can use the landmark of, if male, we can use the nipple line, and in female, we can use the inframammary crease. Electively placed chest tube, especially those designed to drain effusions, may be placed 1 to 2 rib spaces lower or as low as possible in the chest with the use of ultrasound guidance. But we have to use the ultrasound guidance in order not to poke the organ. Okay. The picture above is from the PITS protocol, in which it mentioned that usually we poke at the fourth intercostal space, mid-axillary line. And the picture below is the common diaphragm that we see about the triangle of safety. Okay. So it is about base of axilla, and the lower is fifth intercostal space. The lateral edge of pectoralis major and also the lateral edge of the latissimus dorsi. So this is the safe triangle to put the chest tube.
Actually, if you take as the safe triangle, it should be the lateral edge of the pec major, fifth intercostal space, and also the posterior part is actually the mid axillary line. So mid axillary line is the margin if you take it as a triangle.
Okay, thank you, Doctor. Okay, next about the techniques. First, we need to know the list of equipments needed for tube thoracostomy. In this protocol, it's mentioned that we need the suture set, and then have to have the chest tube, and then the lidocaine for the local anesthesia, the needles and syringe for anesthetizing the skin, the scalpel to incise the skin, the clamp to clamp the chest tube, and the straight scissors, needle holder, or and then the steroid drapes, gown and gloves, and the drainage system is very important. Okay, this is the example of chest tube set. Okay, in which we have the chest drain, and then guide wire, dilator, three-way tape, syringe, and scalpel. Okay, this is a set of pigtail catheter, and then this is the set for cell ginger. Okay, for for thoracostomy, there are two types, in which tube thoracostomy and also needle thoracostomy. So for tube thoracostomy, we have two types of technique, which is the first one is standard technique, and the second one is cell ginger technique. So for standard technique, it is typically used to drain an effusion or hemothorax. More typically, we use it for older adolescent or in adults. As compared to cell ginger technique, usually we use specialty tubes and pigtail catheters using the cell ginger technique. I'll show you the video later. And this technique is usually useful for the placement of the smaller bore tubes that drain air and also non-viscous fluid. And the disadvantage of this technique is its inability to assess the presence of additions between the lung and also pleural space. Because if you use the technique, then you can check if there is any addition between the lung and the pleural space. Okay, this is the steps for the standard technique. I took this from PITS protocol, in which first we have, as I mentioned before, we have to sedate the child, and then position the child with axillary arm fully abducted, and then we have to clean and grab the skin, the area that we want to poke the chest tube later, and then after that we infiltrate the local anesthesia at the triangle of safety and check the length of the chest tube. Okay, for open method, said that currently the open method is the preferred method as compared to the closed method. The closed method is no longer recommended. Okay, after that we make a small incision in the skin just above the fifth. Why above? Because we want to avoid from neurovascular injury, because the neurovascular bundle is at the lower part of the rib, right? So we have to put above the fifth. And then use the blunt forceps to dissect through the subcutaneous tissue and puncture the parietal pleura with the tip of the clamp. And put a glove finger into the incision and clear the path into the pleura. That's why we can check whether there's addition between the pleura and also the lung. And that this may be difficult in a small child because the space is smaller, right? And then
sometimes if you can't use your finger, what you can use is you can use the artery forceps. You use artery forceps to actually open up the path.
Okay, and then we have to advance the chest tube into the pleural space during the expiration, because the lung expands during inspiration, right? So during expiration, can advance the chest tube into the pleural space. For drainage of the air, it said that we roll the child slightly to opposite side because we want to advance the chest tube anteriorly. So we have to roll the child to the opposite side. Can you imagine that? Roll the child to the opposite side so that we can advance the chest tube anteriorly. Okay, we place the tip of the chest tube at the incision and point the catheter tip anteriorly and slowly advance the chest tube. However, for example, in the case of empyema, we have to maintain the child in supine position because we want to point the catheter tip posteriorly As compared to before, we want to advance anteriorly. In Panima, we want to advance the catheter tip posteriorly. Okay. Connect the chest tube to underwater seal. So the water should bubble in pneumothorax and the fluid move with respiration if the chest tube is in the pleural space. And then we have to secure the chest tube by using suture and connect to underwater seal to suction pump. So negative pressure should not be more than 100 millimeter mercury. And confirm the position with the chest X-ray. Okay, this is the same. There's a picture. Okay, this is the video about the standard technique. Can you hear the audio? Cannot hear?
No.
Okay, I'll try to use the browser. Can you see?
Cannot.
Okay, now can you see?
Okay, all right.
Okay. Okay, let's see. Oh, you couldn't hear the audio.
Hazirah, remove your ni ke Hazirah? Your earphone.
Oh, remove your phone.
I think, I'm not sure.
I think just increase the volume.
Increase the volume.
Okay, play.
Okay. Now. Okay.
Aspiration of blood, air, or position the patient supine at a 30 to 60 degree angle to lessen the risk of diaphragm elevation.
Can you hear now? Okay.
And subsequent injury. Raise the arm on the affected side so the palm lays behind the head. Identify the fourth or fifth intercostal space just anterior to the mid-axillary line. Apply lidocaine for local anesthesia at the planned incision site along the expected course of the chest tube and then at the periosteum, intercostal muscles, and the pleura. Aspiration of blood, air, or pus confirms entry into the pleural cavity. Apply a clamp on the chest tube at the desired length of placement. Create a 4 centimeter horizontal incision at the rib below the desired level of entry. Use a Kelly clamp to bluntly dissect a tract through the subcutaneous tissue and into the intercostal muscles. Palpate the tract with a finger, confirming it ends above the rib. With a large closed Kelly clamp, insert the clamp through the intercostal muscles and parietal flora to enter the pleural space. A distinct pop will be felt. Listen and feel for a rush of air. Open the Kelly clamp in the pleural space and withdraw to further dissect a tract. Insert an index finger through the tract and rotate 360 degrees to loosen adhesions and confirm the tract. Grasp the fenestrated end of the chest tube with a Kelly clamp and introduce it into the pleural space, posteriorly and superiorly. Connect the chest tube to a drainage device and release cross clamp. Secure the chest tube in place with a suture and dressing.
Okay, this is in adult lah. In children, don't do like this lah. So this is standard technique, but open technique. So standard dia ada dua, either closed technique or open technique. Closed technique is basically you give counter pressure. So you make an incision and then you push in while someone giving counter pressure. So you push. Memang kita pakai pressure je macam tu. So you are not supposed to actually use closed technique anymore. You should do like this. This is a open technique. So in children, beza dia adalah satu incision dia is not 4 cm lah. 4 cm is basically from nipple to back in children kan. So you just make a small incision, 1 cm or a bit more. Sometimes 1 cm is enough already, or even smaller than that untuk open technique. So you incise and then you open with the Kelly's forceps ataupun artery forceps tu, you open sampai you pass through you dah sampai dekat pleural, you can feel the pleural surface. You puncture, you open a bit. Tadi dia buka tu besar sangat. So you open a bit and then you feel with, if you can feel with your finger, sure that this is the pleural space, and then you push the tube in with another forceps. You push it in, then you push it in. So you don't do it too big like just now, tu besar sangat lah untuk children. Okay, alright, proceed.
Okay, that is about standard technique. Next, we move on to the self-seal danger technique. So I'll show you the video. Okay, can you see?
Okay, so that's going to be the kit that we're going to be presented with when we're looking at a Seldinger chest drain. So if we just open it and go through each bit in turn, and it's wise to check through your kit before you do any procedure, just to make sure you're familiar with everything. So piece by piece, we've got the scalpel for the skin incision, got the introducer needle, the wire's going to be fed along, and got the syringe that attaches to. Got the guide wire that we're going to be placing down the introducer needle. The bevel on the end will unscrew, and then the wire can be fed down. Just moving it between your finger and your thumb. Put that down. Then once the wire's in, we're going to be using dilators. They're of different size and they've got little stops on the end of them to indicate at which point you're going to dilate up to. varying thickness. And you then got the drain, which has got a stylet down the middle of it to feed along the wire, and that will unscrew and come out of it. And then finally, to attach to the drain, we've got the end teat, which is screwed on and attaches onto your drain. Right, so I'm going to start off just by identifying our landmarks and coming down to the right intercostal space. I'm going to clean and infiltrate with lignocaine. Then we're going to make an incision in the skin. Not as big as for an open chest drain. Okay, then going to get our introducer needle and our syringe. Okay, and we're going to aim this into the chest through that incision, aspirating as we go until we find we're in pleural space. Disconnecting the syringe, holding onto the needle. Okay, then going to get our guide wire, place that in, and advance that. Into the chest. Okay, keep your hand on the guide wire all the time. Take the needle out. Get rid of that. Okay. Then we'll take the introducer. And we'll just pass that onto the wire. Dilating up our hole. Okay, take that back out. Go to the next dilator. Dilate that up. And finally the biggest dilator. And dilate the hole to the biggest maximum diameter. Okay. Then we get our drain, which has still got the stylet coming down the middle of it. And we're going to advance this until all the eyelets are actually in the intrapleural space. So again, advancing that through, making sure that don't let go of the guide wire. Okay, and then when it's come out the other end of the tube, hold on to that firmly and advance the drain down the tract you've just created. Okay. Then take the guide wire out. You can then unscrew the stylet from the drain. Taking that out, being aware you may have fluid that comes down the tube when you do that. And attach your three-way tap, closing the drain off for the moment. Screw that on. Attach your drain connector, which goes off onto the drain tube, and then just suture that in place. And then check you're in the right position with your X-ray and your clinical examination.
That is about the Saldinger technique. He said that Saldinger technique is more commonly used in children, but I'm not sure in Malaysia.
Saldinger technique is the best technique for children. It's extremely easy. You can even do it with your eyes closed. It's very, very, very easy as compared to the standard technique. It's extremely, extremely easy. The only problem why it's not being used is it's expensive. So because you need guide wires, you need all the sets, the dilators, I think it is expensive. It is not available in USM, it is not available in HTA, it's not available in HOSHAS, it's not available in IIUM-MC or the new name Sultan Ahmad Shah Medical Center. So we don't have. I don't know which hospital in Malaysia has ability to do Saldinger technique for chest drain, but I think we should go. That is the way we should go. We should actually promote using Saldinger technique for chest drainage, but it's expensive.
Right. Thank you, doctor. So now we move on to the middle thoracostomy. As I mentioned before, there are two types, which is the tube thoracostomy and middle thoracostomy, right? So for the middle thoracostomy, it is done in the mid-clavicular line at the second intercostal space or at the fifth intercostal space mid-axillary line, or some say in the anterior axillary line, with any available kit such as angiocatheter or introducer needle also can be used. And it is indicated in tension pneumothorax as emergency measure before we insert the chest tube because we want to decompress the chest. Okay.
For example, when you have a child that is not saturating, isn't it? You're ventilating a child, the saturation remains very low, less than 50, 40, you're giving very high ventilation setting, but you're still not able to saturate the child. So as an emergency, so sometimes you should just do needle thoracostomy. Just poke with needle. In children, usually we use the butterfly. Why butterfly? Because with the butterfly, at the very end there, you can check. You can put a water. You can put a water, and then you can check whether there's no more, whether there's the air is going out or not. Okay, proceed.
Okay, this is the technique for needle thoracostomy. Can read later. Okay, this is the landmark. Okay. Okay, this is a video. You can also watch later about the needle thoracostomy. Okay, about the level of suction. In up to date, it's mentioned that usually in clinical setting, it use negative pressure of 10 to 20 centimeter H2O of water, and it can be adjusted if there is failure to drain. And commercial closed drainage system, the suction level can be adjusted up to negative 40 centimeter of water. Okay, this is the chest drain system in which there are three pipes, the drainage chamber, the water seal chamber, and also the suction control. Okay, this is about how we want to take care of the tube and drainage system. So for the tube, we have to prevent it from kinking or twisting, prevent tension on the tube or tubing, never clamp unnecessarily, and do not strip the tubing. Okay, the drainage system, usually I've seen in the Google or in the YouTube, they use fluor evac. Must be below the chest, and the drainage system must be kept upright and maintain the fluid levels in the suction and water seal chambers. Okay, this is for the chest tube care. It should be sutured to chest and all connections secured and also taped. Do not allow any gravity dependent loops to form. Never raise drainage container above the chest. If transporting patient, disconnect suction hose. Don't just turn it off. And check the system operation frequently. Check for the fluid levels, fluctuation in the water seal chamber, and also continuous bubbling in the suction chamber. And for milking and clamping the tube, you have to follow the hospital protocol. Okay, what about the criteria for removal? The criteria is different from pneumothorax and intuition. For pneumothorax, we can remove the chest tube when the lung is fully expanded, when there is no visible air leak, and A does not accumulate when suction is removed. And for effusion, when the lung is adequately expanded and the daily fluid output is less than 100 to 300 ml per day in adults. But in pediatric population, I'm not sure because in up to date, it's mentioned it can be less, but there is no studies about the specific threshold for children. Okay, that's all for my presentation. Any question?
Any question? Any question?
I have a question regarding the suctioning rate. In one of your earlier slides, you mentioned that it's in FOB. It should be for the pus, for the liquid pus, and then another one would be the exudative. It has a different suctional rate. Is there any reason? And how how do we control the rate? Is it by adjusting the meter
I
just now?
think sorry.
Wait,
I
what
think
was the question again?
In the earlier slide mentioned that there's a different suction rate for different type of collection. For example, if you have a this slide, rate of drainage is lower for liquid and air, and then depends on the fluid viscosity. Is there any reasoning behind?
I think the reason is because you want to determine the size of the caliber of the tube. So if let's say the rate of drainage is lower, so we can use smaller caliber, and if higher, we can use bigger caliber. I think it is the reason.
Also because you don't want the lung to expand too fast. Sometimes there'll be re-expansion injury. So that's one thing you need to consider as well. Any other question? Any other question? I wanted to annotate actually. Let's see if I can do something. Okay, can you show me okay. Anyone knows anything about underwater seal?
Oh, underwater seal.
Why when you put chest drain, you need to connect to an underwater seal?
To provide the negative pressure.
To prevent entry of air.
To prevent re-entry of air. Yes. Because the thing is, when you have a connection from inside to out, the thing is there is a risk of air from environment going into the chest. So you don't want that to happen. So that is where you have your underwater seal. So your water gives a 1 atm pressure that prevents air from outside going into the chest drain. So this is the purpose of the underwater seal. These are all very canggih punya elay punya chest drain set lah. You don't have this in Malaysia, in most hospital in Malaysia. Like we are not as elay as this. I'm not sure whether do we have this set atrium. This is very good set actually. You can see bubbling. You can see how much fluid. You can see so many things. This is very good actually. So but if in my previous time when I was a houseman, so we just use the bottle with the rabbit ears. So there's 2 hole. Can I let me see if I can draw. Let me try. Oh, janganlah. Slide tadi. Open the slide.
Okay.
Tunjuk slide yang putih pun tak apa. I'll try annotate. Baru nak try draw. Okay. Biasa. Yes, itu. Let me try. If I can draw. I'm not sure if I can draw. I should be draw. Okay, alright. Let me see. Okay, so previously what we have is a bottle like this. Dia ada cap dia. And then dia ada two this straight lah. I'm not drawing. Cancel. Undo. Okay. So dia ada cap dia macam tu. Ni bottle lah, Lepas tu dia ada satu straight. Alamak. Why can't I draw? Okay, sorry. Okay, dia ada satu macam tu. And then dia ada satu lagi tubing dalam sikit. And then this is the water level. Macam tu. So this is the previous old school punya underwater seal punya mechanism. So what happens here? Okay, so we connect the chest drain here. Chest drain we connect into here. So dia ada fluid level there. So air from environment cannot go inside. Sebab dia ada this water level here. Faham? Tapi air daripada keluar, dia masuk, dia akan bubble kat sini, and then dia akan apa ni? Dia akan keluar ikut sini lah. Faham? So this is underwater seal. So air from outside cannot go in because of this, but air from the body can go inside here. Can you see my arrow, my mouse? Cannot alamak, patutlah you minta ni. Macam mana nak buat now? Sekarang? Cursor from Hazirah. Say, let me do something then. Where is the annotation? Mouse, cursor, arrow. Tak boleh lah. Sekarang nampak tak? Tak nampak Tak nampak lah pula. Okay lah, tak apalah. Like this, let me show. Okay, so air from ni body ni orang chest drain we connect here. Okay, so air from this, it goes into the underwater seal there. This is the underwater seal, and it goes there, and it goes out through the shorter bit. So, but air from outside environment, it cannot go inside because of the underwater seal. This is the underwater seal. So this is basically the purpose of the underwater seal lah. So, okay, all right. Any other question? Guys, it's already 2 hours. I think this is. I don't agree to teachings more than 2 hours. I think it's too much, kan? Banyak sangat kan? Okay, wait. Any other question about these two issues we've discussed about chest drain and also about lumbar puncture? Any question? Where are the others? Semua senyap ni. Sudah. Faham?
Any other
Clear?
questions?
Solhi is the other one yang tak present again. Okay. Kenapa?
I have one question. Is there any difference in the way we advance the tip of the chest tube in case of pleural effusion versus in the case of, for example, pneumothorax?
Presenter?
In the slide I have mentioned before that it just mentioned that for impalima it is advanced posteriorly, but for the others it is advanced anteriorly. So I'm not sure between pneumothorax and pleural effusion.
Anyone else has any other suggestion? So basically it's logic lah, kan? Kalau air, where does it go? A goes up, so it's anterior, isn't it? Fluid, it goes down, so it goes posterior. So if an adult or a bigger child, you may put the patient sitting up. The patient may sit in a proper position. So if it's air, ideally you target your chest. It should go the chest drain should go anterior and superior. Anterior and superior. Anterior and cranial. So anterior-cranial. So anterior and cranially. But if it's fluid, it goes down, isn't it? So ideally you should go posterior and caudally. Posterior and caudally. In newborn, for example, newborn as well, you put the baby in supine position, isn't it? But sometimes you do prop up, so almost the same lah. So if it's air is the accumulation is up. If you put the drain down, what's going to happen? You won't drain the air lah, sebab air accumulate dekat atas, kan? So that's why you put the drain, you put anterior and cranial. But if fluid, you put posterior to your chest, posterior to your lung. So posterior and also caudal. So that's the logic behind it. Any other questions? Kalau kita delay Solhi punya presentation with next session boleh tak? Cik Hati tak?
Boleh, tak ada masalah.
Tak cik Hati You maju post kat Facebook. I've spent hours preparing the slide. Then Dr. Syed don't want to listen to my presentation. Cik Hati belakang.
Okay, ada.
dapat hantar surat dekat bos. Macam mana. Okay lah, because I think teaching more than 2 hours is just too much lah. I think it's not good for the brain. Okay, so I think if that is all, obviously it is not. This is not good lah. Teaching medical students procedures is not good. For me, it is not acceptable at all. So, but we don't have any other option at this particular time, in this particular season of COVID. We don't have any other options. We were even thinking of there's so many things. We can do 3D teaching. We can do there's so many things that we can do, but I think it will take years before we can do more 3D teaching or something. It will take years, but it is there. The technology is there. We'll see how things go. But with your group, I think you can just you just have to be satisfied with whatever that is in YouTube for now. But at least, I think there's no other way than you need to give extra effort. I think there's no other option. There's no other option. Hopefully things will get better before your professional exam, and hopefully after your professional exam, if you pass while waiting to become, you're already a doctor at that particular time, while waiting for your placement as house officers, you can come and learn techniques and things in our hospital and also any nearest hospital to you. And I think because learning should continue. Okay, all right. At least these 2 important procedures. I hope you guys can just look at videos. I think it's okay. The other, for next session, we'll have Solhi. You'll be presenting about exchange transfusion, isn't it? It's a bit long to exchange transfusion tu sebenarnya. That's why I think we need to do it in a separate time. And with next session, can we do together with venous access? So venous access, probably one person can present. Jangan panjang sangat lah. One person can present about central venous access. So central venous access maknanya PICC or long line. Seorang lagi present about umbilical catheterization. Okay, boleh. And then kita proceed with Solhi punya exchange transfusion. Okay, all right. I'm sorry to delay this session, but I think 2 hours is just too much. Okay, let's close our session with tasbih kafarah dan salat. Subhanallah. Assalamualaikum warahmatullahi wabarakatuh.